Hey everyone, Deb Getz here. I'm a physical therapist and I've been an educator, consultant in physical therapy for about the last 15 years. And never before in my history in the profession have I ever had to deal with something like the functional limitation reporting. It's just daunting. So I put a question out to the community a few weeks ago asking them what are their top 3 questions regarding functional limitation G-coding. And I was really surprised about the response. It seems that a lot of people are having confusion with the ins and outs of limitation reporting. But the one thing that people seem most concerned about was managing all this reporting and getting our patients better as quickly as possible. So I've decided to dedicate a whole video just to that, coming up to you in just a few days. But for now, here's the questions and answers that you guys submitted, top 3 with our answers. Keep those questions coming, and I'll see you next time. Our first question is regarding reevaluations, and reevaluations are a difficult topic, I think, because of the way that what we're mandated to report with G-codes. We are mandated to do an initial evaluation, and then every 10th visit, we need to do the same objective test, which seems to be a reevaluation, but in fact, we traditionally will not be billing 97002 with the 10th visit. So the question was, when do you report G-coding for your 10th visit if you do a reevaluation, let's say on the 6th visit? Again, I'm not sure if this question is regarding a true reevaluation, 97002, or just the second evaluation of the functional G-code reporting. But the answer either way is that you would go ahead and you would bill current and projected G-codes on the day of a reevaluation, if it is 97002, and bill subsequent G-codes on the 16th visit, which is 10 days later, or at discharge, whichever one comes first. Remember that G-codes need to be billed with the following CPT codes: 97001, 97002, 97003, and 9004 at or before the 10th visit, and at discharge from the therapy episode when the patient has achieved their functional limitation goal and will be continuing with therapy for a new functional limitation, or just traditional discharge from therapy. So again, in this instance, are they doing a true reevaluation, or are they just evaluating again and doing an update for their patient with regard to G-coding? Either way, the subsequent coding would be 10 days after that visit. So if it was on the 6th visit, it will be the 16th visit. But now, since there's such confusion about reevaluations, I want to talk about what the reevaluation of the 97002 for PT and 97004 for OT. And the rules from CMS regarding reevaluation are as follows. A therapy reevaluation is separately payable if the documentation shows significant and unexpected change in a patient's condition that supports the need to perform a formal reevaluation. So from soup to nuts. So let's say your patient is being seen for a hip replacement and falls and injures their shoulder and cannot use the walker. That would be an instance where a reevaluation would be indicated because there was a change in functional status. And that's when you would bill 97002, and again, with your functional limitation G-codes, you would need to report the current and projected G-codes with that 97002 CPT code. It also will be done, the 97002, when you need to reestablish appropriate treatment goals and interventions, again, when there is a change of status. Reassessments, which is what I think that person was referring to in her question, is considered a routine aspect of the intervention and not billed separately. So when you are billing for your 10th G-code, 10th visit G-code, you will not bill 97002 unless there has been a change in functional status. That would be considered a reassessment. And again, there is a lot of confusion regarding this CPT code, especially with regard to the rules with the functional limitation G-codes. Second question is about how Medicare is going to handle the now instituted deadline for reporting. And since the date of formal implementation of Medicare G-code reporting is July 1st, 2013, how will CMS track what has been billed and documented prior to that date? The true answer to that question is we really don't know how CMS is going to handle it. But it is the understanding that CMS will be tracking for patients after July 1st only, and therefore you will only need to submit G-codes when appropriate for the patients after July 1st. Now, if a patient has begun physical therapy in June or May, it would be prudent of you to report a G-code functional limitation reporting at their 10th visit and discharge, even if you have not submitted one for the initial evaluation, since the implementation is starting in July, and if they are going to be continuing with therapy in July, that should go ahead and be reported. Again, you will be reporting for G-codes with the following CPT codes as mentioned before, initial reevaluation, and for any new and existing patients that will be continuing with therapy after July 1st, 2013. And finally, the question 3 had to do with functional outcome tests. And how do you choose an appropriate functional outcome test? And what type of test do you use if your patient has a diagnosis that doesn't affect function? Well, again, that would be under the G codes of other, and with regard to functional outcome tests, CMS really doesn't care whether the functional outcome test necessarily reflects the outcome that you are reporting on. And I realize that that is counterintuitive and quite frankly does not make any sense to me. But you will just need to perform objective tests that have been proven reliable and valid in the literature for function. Try to make them as appropriate as possible. APTA recommends picking 2 to 3 special tests and performing them even if they cannot represent the functional G code upon which you're reporting. A good tool to use is a subjective survey type of evaluation like the optimal or the Swestry, that kind of thing that covers very different functional tests throughout, and be able to use one of them to reflect the functional limitation or the severity modifier and percent limitation that you are going to be figuring out and performing on your patient. Good questions, everyone. Keep them coming, and I'll look forward to answering some more in the future.